Hi, everyone. We're going to go ahead and get started so that way we can allow ample time for our speakers here and have some great time for questions at the end. So thank you, everybody, for coming to our Senior Resident Grand Round series. Today is our last installment in the series, and we have two fantastic speakers to wrap it up. So I'm really excited for Dr. Alexa Loncharich and Dr. Tyler Daugherty. I learned how to pronounce his last name today, so it's a big accomplishment for me. And so they're going to give some phenomenal presentations today. So first, we're going to have Dr. Alexa Loncharich come up and present her presentation. She is originally from Indiana. She attended the Indiana University School of Medicine before she came here for internal medicine residency, and she is currently applying to hematology oncology fellowship. Dr. Loncharich.
All right. Thank you, Millie, for the warm introduction. I'm really honored to be here today to speak with you all and to wrap up our excellent lecture series from the senior residents. Today, I'm going to chat with you about bleeding and stroke risk scores in patients with cancer and atrial fibrillation. I have no disclosures. Atrial fibrillation is an incredibly common arrhythmia. It affects 3 to 6 million people in the US and is projected to affect 6 to 16 million people in the US by 2050. The lifetime risk of developing AFib is 1 in 4, and the prevalence increases with increasing age. Males are more likely to develop AFib, and actually recent research has shown that patients with cancer have an almost twofold increased risk of developing atrial fibrillation, with the highest risk being in the 90 days following their cancer diagnosis. So why do we care about atrial fibrillation? One reason is that atrial fibrillation is associated with an almost 5-fold increased risk of stroke, and stroke carries significant morbidity and mortality. It's the second leading cause of death worldwide, and it leaves half of its survivors disabled. The risk of stroke in atrial fibrillation is incredibly variable, with annual rates ranging from less than 1% to over 10%. So how do we know who is at high risk of developing stroke and who is not? Several risk scores were developed to address this question, CHADS and CHADS-VASc. For the purposes of this talk, I'm mainly going to focus on CHADS-VASc because it's what's recommended in guidelines. On the right of the screen, I don't know if you can see my mouse over here, you'll see a chart with CHADS and CHADS-VASc scores with their associated point system and the risk for ischemic stroke based on the points. CHADS-VASc takes things into account like heart failure and hypertension and stroke. And all of these points add up, and patients with a score of 2 or more in males or 3 or more in females are considered high risk for developing a stroke. Patients that are high risk for developing stroke are recommended to receive oral anticoagulant therapy to reduce the risk. Oral anticoagulation is the mainstay of treatment because we know that it reduces the risk of stroke by about 2/3. However, like all things, it's not without risk. And here, the annual risk of anticoagulant-related major bleeding is about 5 to 6% in clinical trial eligible adults. Similarly to stroke, where there's increasing risk at increasing age, there's also increasing risk as we increase in age for major bleeding. So it becomes really important that we accurately identify the risk of ischemic stroke in order to balance the benefit of stroke reduction with major bleeding risk on anticoagulant therapy. So we've discussed how we look at stroke risk. We also have risk scores for bleeding risk. And there's been numerous scores developed. I'm going to touch on a few of them here. HAS-BLED is probably the score you're more familiar with. It was developed to look at major bleeding in atrial fibrillation. And major bleeding is bleeding where there's fatal bleeding, bleeding that requires 2 units of blood or more, or bleeding in a critical area, things like intraspinal bleeding or intracranial, pericardial, etc. So Has Bled was developed from the EuroHeart survey data and then validated in a cohort of patients on warfarin versus a DOAC. In contrast, Atria is another risk score in atrial fibrillation, but it looked specifically at major bleeding associated with warfarin. Orbit was a score that was developed in oral anticoagulation and validated in the Rocket AF cohort of patients, so patients receiving rivaroxaban and warfarin. And then the last score I'm going to touch on is hemorrhages, which was developed by our very own Dr. Gage here. And it was developed and validated in a population of patients that were on various things, such as warfarin and antiplatelet. So here, I've told you a little bit about how they're all of these scores are developed in slightly different populations, but they share a lot of similarities. So I've put together a table with some of the variables that they're all taking into account. And you can see that all of the scores are looking at age and prior history of bleeding, renal disease. They do have slightly different cutoffs for things like different ages, different renal disease cutoffs for their GFR, and different definitions of liver disease, alcohol use, and hypertension. All that is to say that there are different tools that we have in our tool belt for accurately identifying the risk of bleeding so that we can balance it with patients' risk of ischemic stroke. Cancer adds an interesting variable to the mix because patients with cancer have an increased risk of thromboembolism, including arterial, and an increased risk of bleeding and anticoagulant-related bleeding. So the balance between the anticoagulant-related bleeding with the decreased risk of ischemic stroke on anticoagulation becomes a lot more delicate in this population. The accuracy of these risk score models is really not known for patients with cancer. A recent study looked at patients with atrial fibrillation that were not on anticoagulation, that were deemed low risk by CHADS-VASc. And what they found was that patients with cancer had a threefold higher 12-month cumulative incidence of arterial thromboembolic events. So essentially, patients that are deemed low risk by CHADS-VASc are having a high rate of event. And this study really challenges the accuracy of our risk score models, specifically for ischemic stroke, in patients with cancer and AFib, and the cutoffs that we use to define risk in this population. So with our research, we wanted to look at the discriminative performance of CHADS-VASc in patients with cancer and atrial fibrillation for the prediction of ischemic stroke, as well as look at the performance of bleeding risk models for the same population, patients with cancer and atrial fibrillation, for clinically relevant bleeding. To this end, we identified ICD codes for cancer in the Veterans Health Administration data. Patients were included if they had a new diagnosis of cancer or an incurable cancer. We then identified the patients of these that had a new diagnosis of atrial fibrillation. And we came out to a cohort of about 13,000 patients. We separated them into 3 groups based on their prophylaxis. So those on full anticoagulant therapy, those on antiplatelet only, and those on no antithrombotic therapy. In addition, we also identified a subgroup of patients that were on active chemotherapy around the time of their AFib diagnosis. And throughout this talk, I'll refer to them as the chemotherapy cohort. So here is the baseline characteristics for our full cohort. There are some differences highlighted in blue, and I'll point out that the median overall survival for patients on anticoagulant therapy was a little longer than those on aspirin or no antithrombotic therapy. Those patients on no antithrombotic therapy had a decreased rate of hypertension, heart failure, prior stroke. And you can see that also our anticoagulants used in the study were predominantly DOACs, though there was a large portion of patients on warfarin as well. The baseline characteristics for the chemotherapy cohort was very similar, so I didn't include another table, but the major difference was a lower median overall survival in this population. The cancers represented in our cohort, lung followed by hematologic and prostate and GI. In our chemotherapy cohort, almost a third of the cancers were hematologic, followed by prostate, lung, and GI. Here, we are looking at graphic representation of the prophylaxis by CHA2DS2-VASc risk score. And I'll orient you on the left. The bar on the left is looking at patients with a low CHA2DS2-VASc risk score of 0 to 1. And on the right, the bar is looking at those with a high score, so 2 or more. And the percent of patients receiving anticoagulation is shown in red, antiplatelet in blue, and no antithrombotic therapy in gray. And what you can see is that over half of patients that are deemed high risk by CHA2DS2-VASc are not on anticoagulant therapy in our study. The same holds true for the chemotherapy cohort, where over half of patients that are deemed high risk are not prescribed anticoagulant therapy. For our study, the mean CHA2DS2-VASc was really similar from the full cohort and the chemotherapy cohort, as well as the 12-month cumulative incidence of ischemic stroke. The 12-month cumulative incidence of major bleeding was slightly higher in the chemotherapy cohort compared to the full cohort. So when focusing on the patients in our study that were on antiplatelet therapy or on no prophylaxis, in the full cohort, which is the top table here, there is a significant increase in risk of ischemic stroke for each 1-point increase in CHA2DS2-VASc score. However, when we're looking at the ability of CHA2DS2-VASc to tell whether a patient with cancer will develop ischemic stroke or not, the discrimination here is poor, with a C statistic of 0.56 and 0.54 in the no prophylaxis and antiplatelet groups. And C statistic is a measure of discrimination that's really should be between 0.5 and 1, with 0.5 being random chance. We're flipping a coin to determine who's going to develop ischemic stroke. And then 1 would be the perfect model, where we're always telling who's going to develop an ischemic stroke or not. So here, 0.56 and 0.54, we're doing better than flipping a coin by a little bit. And then looking at the chemotherapy cohort with the same type of analysis, which is the bottom table here, you can see that there is no association between CHA2DS2-VASc score and ischemic stroke. In addition, the discrimination here is poor, with C statistics of 0.53 and 0.5 for the no prophylaxis and antiplatelet group. Switching gears a little bit, we'll talk about bleeding risk scores. I'll preface this to say that the numbers for the cohort vary just a little bit from the stroke cohort because the cohort was defined by the start of anticoagulation. And here we're looking at the full cohort and the patients that are on anticoagulant therapy. So for each 1.1 standard deviation increase in the scores, all of the scores have an increased risk of bleeding. And here we're looking at standard deviation increase instead of point increase, like we did with CHA2DS2-VASc, just to allow us to compare between the scores, because all of the scores have different point systems. The C statistics here were pretty similar across the board, with Atria and Orbit being 0.61, so more in the modest to moderate range, and then Hasbled and hemorrhages being at 0.62. So here's a similar analysis, but looking specifically at the chemotherapy cohort. And looking at the risk models, atria didn't have any association between bleeding and the points for atria, but has bled, hemorrhages, and orbit all had an increased risk of bleeding with each increase in standard deviation. The C statistics here are a little bit more variable, with atria being in the poorer range at 0.55, and then hemorrhages at 0.57, has bled doing a little bit better, kind of in the modest to moderate range at 0.6, and orbit at 0.61. So we took it a step further to look at specific variables in the available risk models to see if they predict anticoagulant-related bleeding in patients with AFib and cancer. And in the full cohort, a lot of the variables do have a significantly increased risk of bleeding. So history of bleed, anemia, antiplatelet use, history of prior stroke, they're all associated with an increased risk of bleeding. However, when we look towards the chemotherapy cohort, we lose a lot of the association with these variables. So the only ones that remain significantly associated with an increased risk of bleeding here are history of prior bleed and alcohol abuse. When looking at more cancer-specific variables, we did find that location and metastatic disease were associated with an increased risk of bleeding. So patients that had a GI or GU cancer were associated with an increased risk of bleeding. However, in the chemotherapy cohort, only race was significant for an association with bleeding risk. So to conclude, CHADS-VASc poorly discriminates the risk of ischemic stroke with patients with AFib and cancer, and that our bleeding risk score models only modestly predict bleeding events in patients with AFib and cancer, which kind of tells us that classical predictors of arterial thromboembolism and bleeding are really not sufficient to predict the risk of stroke and bleeding, respectively, in patients with AFib and active cancer. And refining available models could improve prediction in cancer. There are limitations to the study. This is health administration data, which has its own inherent limitations. It's a VA data, so it's pretty male predominant. And postoperative AFib was not included as well. In the future, we plan to assess the association between prophylaxis with development of ischemic stroke after adjusting for treatment selection by CHADS-VASc score. And we also plan to assess the gain in discrimination of available bleeding risk models with the addition of cancer-specific variables. I want to say thank you to my mentor, Dr. Sanfilippo, who has heard me talk and seen these slides way too many times, as well as other members of the team, Dr. Gage, Su-Hong Liu, Dr. Leader, as well as the chiefs and Dr. Chang. And I will hand the mic back over to Millie so that she can introduce our next speaker.
From Savannah, Georgia, and then went to Emory University School of Medicine, where he got his MD. He then joined us here for internal medicine residency. He is currently applying to GI fellowship. So Dr. Daugherty.
Thanks, guys. 1 second, I'm going to flip around where things are. All right, I'm failing. I did not. There we go. That's good. Thank you. Oh, I'm so sorry, guys. Yep. Nice. Now we got it. All right. Hey, everyone. I'm Tyler. Thank you for having me today. Today, I am going to talk about the images that you and I and trainees and attendings see when we look to references on skin conditions. As a case study for most of this, I'm going to talk about rheumatology. It's an area where I've gotten to do some work in education with Dr. Lisa Zucker and a team here. But as I'll talk about, this extends far beyond rheumatology. I'm going to talk about this in three parts. So first, I'm going to talk about where we were. This is around 2020. It's not a great year. I'll summarize that year a little bit for you. But that's where we're going to start out with looking at these education references in terms of racial representation. Then I'm going to talk about where we are now. And this is some of the work that I've gotten to do over the last couple of years. And I'm also going to talk about why it matters. So I have no financial disclosures. I do have another disclosure, though. I am a whitish male. I am Filipino and Irish. Most people think that makes me look Italian. That is funny. And because of the way I look and the way who I am, there are things that I can absolutely never understand about the experience of people of color within medicine. I am trying to understand, and like a lot of you, I'm trying to make the system better also. So let's get started. Where we were in 2020. This is not a good year. COVID has started. Meghan and Harry left the royal family for reasons also involving race. Kobe and his daughter died, and it certainly didn't get the press of any of these things. But Dr. Straight and colleagues published a paper on race, ethnicity, and disparities within rheumatologic education materials, and that's going to be one of the foundations for my talk today. What they did is they looked at 4 of the main resources that we use whenever we're looking at cutaneous conditions, what we look to as reference and also what's used in education. And they separated the images within this into dark and light skin and compared percentages, essentially. They broke that up. They looked through all of these rheumatologic references, and they used the Fitzpatrick skin scale, or the phototype scale. And the dividing line here was 4 and 5. 5 and 6 of a Fitzpatrick phototype being dark skin, everything else being light skin. This is one of several ways to break this up that's used in literature. I'll talk about a few different ones over time, but this is the one that they used. The references that they looked at were the American College of Rheumatology's Image Bank, up to date, the New England Journal of Medicine's Images in Clinical Medicine and Clinical Cases, and then the Kelly Blue Book, which is not the Kelly Blue Book. It is Kelly and Firestein's textbook of rheumatology. However, I couldn't find a Creative Commons image for that. So for today, it's going to be the Kelly Blue Book. They searched all these things on October 31st of 2020, or at least the first 2, the ACR and up to date. They then looked at New England Journal on all of those published within that area in rheumatology up through October 31st of 2020. And then finally, they looked at the 9th edition of the Kelly Blue Book. What did they find? So for ACR's image library, they found 538 images, about 13.6% representing dark skin, Fitzpatrick 5 or 6s. For up to date, they found 265 images, about 17.4% representing dark skin. For the New England Journal, they found 85 images and 11.7% representing dark skin. And then finally, in Kelly's textbook, they found 155 images and 7.1% representing dark skin. From all of this, they take it together and they conclude that there is 13.4% dark skin in these 4 core rheumatologic reference materials. And what they do is they compare that to the US population, US Census from around that year that had people identifying as either Asian, Indigenous people, or Black. This is an interesting comparison, I think, because certainly not all of those who identify within those groups have Fitzpatrick 5 or 6 skin types. It's probably an overestimate of the representation within the US with dark skin, but it's what they compared it to. They decide that compared between these, there's a significant reduction, and they come to the conclusion that there is a significant underrepresentation relative to that. One really compelling piece of data from this, though, is in specifically the lupus population. So within lupus, 22% of the images were of people with dark skin, compared to the 44% disease burden of those with lupus, or of those who identify as Black. And so this is a very compelling underrepresentation relative to the disease burden. This is something that's been demonstrated multiple times, including by one of our colleagues here at WashU, Ahmad Rana, and Dr. Zucker looked at this in a paper on lupus skin color representation. They looked at a very wide range of resources. This included online textbooks, skin of color atlases, medical journals, the ACR image library, Visual DX, up to date, and then also just general Google images from May of 2014 through May of 2019. They searched for the terms lupus and lupus rash, and what they found was profound underrepresentation in their 1,500 images. About 56% of them were light skin, and the rest were in the scale of medium to dark skin. This was a slightly different scale than was used for the straight paper. It's a scale of 0 to 10, and each of those divided into light, medium, and dark skin. And more than half of these images in these references for lupus and lupus rash were of light skin. So rheumatology has a problem, but so does any field where skin conditions are prevalent. Dermatology. Lester in 2019 published a review on dermatology references. Primarily, these were textbooks and compared skin of color to non-skin of color images. The dividing line here is the Fitzpatrick 3 and 4. So 3 and less was considered non-skin of color, and 4 and greater is considered skin of color. They found that only about 22 to 30% of images were people with skin of color, the remainder being non-skin of color. It's also a problem in plastic surgery. This is from a paper by Massey in also 2019 that searched 6 plastic surgery journals, as well as the New England Journal Images in Clinical Medicine for plastic surgery cases. They looked through from 1990 on, and ultimately found that, again, in that comparison of skin of color to non-skin of color, it was in that 20 to 30% range. And they specifically in their article talk about the comparison to the 60 to 70% of people worldwide who have skin of color in their estimate, and consider this again an underrepresentation in our reference materials. It's also a problem in medical education generally. So this is a really fascinating study from 2021 looking at USMLE preparatory materials. They looked at USMLE step 1, step 2, UWorld questions, and looked through all of these images again at the 3 and 4 Fitzpatrick skin phototypes, and found in that same range 20 to 30%, around 25%, and with UWorld for step 1 having the lowest representation of skin of color. This leads to a cascade of problems and is entwined in a cascade of problems. And more broadly, it's an underrepresentation of BIPOC, which is a term meaning Black and Indigenous and people of color. It's a term that seeks to emphasize the particular relationship that Black and Indigenous peoples have had to whiteness and to the medical system in this case, but it also tries to encompass people of color. Any term that groups a lot of people together can be flawed. But it's the one we're going to use here because we think it probably speaks to what we're talking about specifically in relation to the medical system. So underrepresentation of BIPOC transcends specialties. Related to this also is that clinical images are key to developing clinical acumen for cutaneous diseases. Skin of color impacts how cutaneous diseases present, and an image for one skin tone doesn't really help us for other skin tones. Building on all of this is that rheumatology outcomes among BIPOC are worse. There's a great deal of evidence for this. In particular, I'm going to talk about lupus and RA. So within lupus, there's a review by Lewis that found that there was higher incidence and prevalence of SLE within these populations, which we know about, but there's also lower adherence to medications for reasons relating to mistrust, cultural attitudes, poor communication, health access, and chronic socioeconomic stressors. And then also within lupus, BIPOC have higher mortality. This comes from a review by Peshkin that looked at a bunch of different populations that are within the BIPOC umbrella. Indigenous peoples have a mean age of death of around 50 compared to 64 in white individuals, is brought up there. Lupus was the 10th leading cause of death of white women aged 15 to 24. And within Black and Hispanic populations, it was the 5th leading cause of death. And then there's also a Canadian study that found Indigenous North Americans to have a 2x mortality relative to white lupus patients. It's also a problem in RA. Two studies that I'm going to talk about here. There's a study by Greenberg, which was a US registry study from 2023, essentially finding lower remission rates of RA among African Americans. And then there's also a study by Hitchin that I reference here, was a cohort of Indigenous North Americans that found lower remission rates among Indigenous people despite having access to advanced therapies. So BIPOC have disparate healthcare outcomes in rheumatologic diseases, but we also know that that's true in many other diseases, unfortunately. In the field that I'm hoping to go into here, GI, BIPOC are less likely to be screened for colon cancer. They also have higher incidence and mortality than white individuals. African Americans are 30% more likely than whites to die prematurely from heart disease, also more likely to have high blood pressure and more likely to have that high blood pressure not well controlled. Black individuals with diabetes also have higher mortality. Sorry, I was a little behind. Have higher mortality than white individuals. So all of this cascade of problems, I think, leads us to a conclusion, or at least me and our team, that there is a disconnect between what education materials are preparing us to do and then what our experience is within clinics. That disconnect specifically for cutaneous diseases raises the risk for delayed diagnosis. That uncertainty in the physical exam also leads potentially to mistrust. And the piece that I'm about to share with you guys is not specifically from a patient's experience, but I think it's a really powerful narrative on the potential for mistrust when our education doesn't necessarily take that into account. So this is in a piece by LaShira Nolan called How Medical Education is Missing the Bullseye. She was a medical student at the time. And one of the really salient quotes from this is, she's in a medical school lecture, pathology, Lyme disease comes up. And the professor shares this very clear finding that a hallmark of stage 1 Lyme disease is a bullseye rash, erythema migrans, that typically appears 3 days after infection. And behind that professor was an image from the CDC of that rash on white skin. One of her colleagues in the room brings up, how do you recognize this rash on darker skinned individuals? And the professor for her said that it's harder and moved on. And that was a really salient experience for her. And finally, since medical education forms the foundation for us as providers, doing it wrong can perpetuate disparities. Some evidence for this is an internal medicine report from 2003 that I was specifically on unequal treatment. They found that the physical uncertainty within the physical examination or physician perception of clinical signs was they identified as a major contributor to the disparities of care for minorities, in their words. With all of that in mind, I want to take us back to 22, when Straight published this paper, and the response to this and many other things that were happening around that time. Some of these references that Straight had studied in this published some responses, or at least made an effort here. The ACR dedicated the 2022 image competition to skin of color to increase representation and enhance practitioner learning. The ACR and NEJM also issued calls to their author bases requesting increased people with skin of color image representation. And then several textbook publishing companies inserted guidelines into their author instructions to enhance diversity among images and figures that they publish. And the question remained for us was, did that work? So this is where we were with the data from Straight, and we, over the last year or two, have tried to update this and see where we are today, or at least back in October of 2022. So when they had looked on October 31st of 2020, we looked on October 31st of 2022 for the first two references. For the New England Journal, they had looked on October 31st and everything before it. We looked at everything published after that. And then finally, for the Kelly Blue Book, we used the 10th edition, not the 9th edition. What do we find? For the ACR image library, when there were originally 538 images with 13.6 representing dark skin, now there were 873 images, 18% representing dark skin. This was a trend toward significance, not a statistically significant difference. For up to date, there were originally 265 images and 17%, and now there are 236 images and only 9% or so representing dark skin. That was not a significant difference, but a trend towards decrease. For the New England Journal's publications on this, originally there were 85 images and around 12%. This is only a 2-year window instead of the entire history of publication within those areas. So we find far fewer images, only 19, but a much higher percentage of those with Fitzpatrick 5 and 6 skin types. And that was a statistically significant difference. And then finally, for the 10th edition of Kelly, there were originally 155 images, 7.1%. Now there were 138 images in that 10th edition and 13.1%, a trend towards increase, not statistically significant. So this is where we are, October of 2022. And the one really interesting one here is this, right? There's a huge drop off between these. So we actually reached out to UpToDate about these findings. And they got back to us. They took this very seriously in their response to us. They said, thank you. They said, this is important to us, and we remain very committed to this. They said that they have been working to increase diversity in our images and are going to continue to. They said they convened a working group and evaluated their own images in June of 2023. And they say that their results were different from ours. What they say is that they found an absolute increase in rheumatologic images for dark skin, up from 44 back in 2020 up to 56 now. But they acknowledged in their analysis that that percentage went down from 18% down to 16%. Another thing that they bring up that's pretty interesting is that not all UpToDate subscribers see the same images. So depending on your licensing and your institution's license and things that I really don't understand, there are third-party image partners, and so you don't necessarily see all of the images that they have available. And in their entire group of images, which was many more images than we saw in our analysis, 35% of them were of individuals with dark skin. The big takeaway here, though, I think, is that even with their own in-house analysis, that percentage dropped. So I want to close with some final thoughts, teaching points, takeaways. First off, the resources that we seem to think made strides towards increased representation in their images did two things. First off, they outwardly demonstrated an awareness of a problem and a need to change and a willingness to change, as well as they publicly outlined and implemented a strategy. I think we see this with the ACR's image competition initiative in 2022. We see this with the call to authors for ACR and NEJM. And we also see this in the adjustment of like textbook guidelines for trying to add representation in their images. The next take home I want for us is that I think I want to, and I think we all should continue to acknowledge the courage and the generosity of BIPOC individuals whenever contributing to these images. These are often communities of color with very challenging relationships to medicine historically, and contributing to medicine takes a lot of courage. I think we should also have appreciation for the collaboration required for this. This requires collaboration between patients and providers, but it also requires collaboration between multiple institutions and multiple providers in order to create fully diverse image sets. You can imagine that certain areas of the country do not represent the entire world or the entire country. And so we need images contributed by patients and providers and institutions from across the country and across the world. I also think that there's a huge opportunity here for large databases. Databases are dynamic. They allow us to make a change centrally and have that propagate through a larger healthcare system. And so that's a huge opportunity for us. I think I've already talked about the collaboration part. Finally, I want to remember the fundamental nature of medical education in improving capital M medicine. It is really, really hard to prove causality between any of the changes we make in medical education and then the long-term health outcomes that come from that. But any initiative that seeks to improve the care for people of color or their comfort within the healthcare system is, I think, an initiative worth pursuing and has really great downstream potential to improve a very flawed system. Thanks. I also want to thank a few people. Dr. Lisa Zucker for her time and guidance and expertise on this project. Dr. Cow and WUTIP for creating the opportunity for me and many others to do education scholarship here. And then Dr. Fritz and the DEI program here for their incredible work on campus, improving this aspect of our program and the profession generally. Thanks. What? Oh, sorry.
So thank you both for those terrific talks. I think there's time for a few questions. I'll start. So if you were going to update risk stratification, do you have a sense of what else needs to be addressed to get better risk prediction models for ischemic stroke and bleeding intervention?
So I think with the bleeding, I think the addition of maybe metastatic disease or location might be beneficial based on the significance with the bleeding risk that we found in our univariate analysis. But the hope is that we do that in the future and we figure out, if adding things like that does improve the score.
Yeah, I don't know, Tyler. It's kind of shocking to hear about updates like reversal or decline in the amount of such as publishing or information about it. Did they talk to you at all about their process, about how they were doing?
Yeah, they sent us a very long email in response. They said that they followed Straight's original methods from 2020, and they did this at a very different time than we did many months later. It's possible that things were very different. It's also possible that we're looking at slightly different images. They sent us a long spreadsheet as well with all of their data to corroborate their findings. I think it's a more private institution than a lot of other things that we were looking at here. And so it's a little bit more of a black box, but they did try and provide methodology, and they didn't specifically talk about how they scaled those images or rated those images. For us, we had two separate ones and then a tiebreaker, and so did Straight, and many of these other processes. They didn't specifically talk about how they went about rating the images, but they did provide us with, they said they followed the original methodology and provided their data to us.
So dermatology here has done a lot of research in this area also and identified, very similar findings of inequities in people of color among derm textbooks and research as well. So they actually have done a number of interventions as we did for dermatology.
It was her.
At similar results, with some increases, but not.
See kind of the cardiovascular activity that doesn't have like we're supposed to be pretty poor overall for the cohort. Do you see like when you broke down like cancer type or like prostate having gene therapy that you saw better predictive ability, or was it pretty poor even among individual cancers?
So we haven't yet looked at individual cancers in prediction of that. So what we have right now is just overall. So I can't tell you what it looks like based on each individual. Yeah, I mean, I think it's really hard because there's such heterogeneity in different cancer types. The one benefit is that the cancer population is almost a third hematologic. So I think that that's like decently well represented in there. And certainly stopping based on counts could be associated with the performance as well.
Won't be able to measure it. This is that they delay the certain mental factor.
So Tyler, what else do you think people could do to increase the numbers? Because there were those, initial calls and incentives, but obviously there's been a lot of progress. Other ideas?
I think in part it's time. We've had 2 years of these initiatives, and as we see increases in it, I think that continues to build over time. As far as other ways to go about it, I think it's continued work in similar ways, not losing steam on the original initiatives and continuing to make calls for that until we get to a place where there is good enough representation.
Chemotherapy within rate factor for we thought on why that would not do it.
No, I thought it was very interesting as well. And I spent some time this morning looking up race and how that could affect it. And all I found is just in atrial fibrillation that there's a disparity in getting anticoagulants for patients. And in those studies, they had an increased risk of bleeding for patients with just atrial fibrillation that were Black, which is not at all what I saw here. And so I have no idea why our results were what they were. I don't know if Dr. Sanfilippo, if you have any insight into that.
VA. So I was encouraged, you could consider doing some of these disparate outcome studies in the VA as well, because we see the same outcomes in the non-VA population in terms of cancer outcomes, where African Americans or persons of color tend to do worse, but when you do the same analysis in the VA, it goes away because they have equal access to health care and utilize. But I could not think of a good idea when we saw that and not expected. And when we look at venous thromboembolism and the same question, we don't do that. So I don't know if we should be able to here, but then you would think it would.
Mhm. Certainly. Yeah, the one I referenced by Ahmad Rana and Dr. Zucker there used a different scale. I can't remember the specific name of it right now, but it's a 0 to 10 scale, so a lot more data points within that, and then divided into light, medium, and dark skin. I believe it's at 3 and 7 or so where those dividing lines come. So a little bit higher resolution for that scale, I'd say. In that study on lupus specifically, about 55% of images were light skin in that very end of the higher resolution spectrum, with the remainder of them representing medium and dark skin. So certainly, Fitzpatrick is, like any scale, is flawed and breaks it up very binary. There does seem to be some evidence that lighter skin is also overrepresented, even without that wide of a net.